بسم الله الرحمن الرحيم.
السيشن دي معموله خصوصا عشانكم يعني.
والصلاة والسلام على أشرف المرسلين. يشرفني إن أنا أقدم يعني أنا حتى شهادتي مجروحة يعني إن أنا أقدم أخ يعني فاضل وعزيز عليا جدا وشخص حبيب جدا. أنا مش هقدمه من ناحية كمان يعني كعالم لأنه ده بابست اوف one of the bubbles of nuclear medicine يعني مش محتاج ان اتكلم عليه خالص يعني انا اقل كتير من ان انا اتكلم عليه، بس انا هتكلم عليه كاخ يعني وكشخص بار باسرته ويعني ابتداء من والدته بالذات يعني ربنا يديها الصحه بكليه طب اسيوط بمصر بالوطن العربي بتاعه، حتى كمان بار جدا بشغله بوطنه الثاني اللي هو امريكا. فانا يعني فخور جدا ان انا اتعرفت على هذا الشخص، ربنا يديله الصحه وما يحرمناش من وجوده معانا دايما. ومش ما هو يعني ده شرف لينا يعني. انا مش هضيع ولا دقيقه بقى يعني، هقول لكم بعد ما يمشي هقول لكم عليه كتير لان انا عاشرته كتير يعني.
اتفضل. Thanks so much for your generous kind introduction. يعني الواحد بيحس انه اللي زي حالاتي جات له ظروف ان هو يبقى في مكان ويتعلم فيه we have the duty to help. فيعني في أي وقت من الأوقات أي حد needs anything الواحد يحس إن ده واجب مش تفضل يعني. وإن شاء الله جمعية كل سنة على قد ما الواحد بيقدر يجي فيها إن شاء الله. I know that this is not a familiar setting. إنما it's not uncommon, especially in national meetings, that there will be sessions for kind of interactive sessions. The idea is not to diagnose the disease itself, but it's just for the relatively younger people to learn how to think. So sometimes what matters is not that you find out what the diagnosis of this case, because that's kind of more pattern recognition. And if you know you have seen a case like that, you may recognize it immediately. But it's how you go about it. It's the thinking process. And don't be afraid to make mistakes. That's the time that it's okay to make mistakes, and you learn that we all make mistakes. So don't take that as any stress-inducing kind of thing. I'm going to do this. I'm going to present the case to you, and then we'll just go by order, and everyone will take a case. It's a total of 10 cases. And we're just going to learn from each other. I may learn something from how you're describing the case, and you may learn something from me that's something maybe you didn't hear, or maybe you heard it before but you forgot about it. Okay? Deal? And just do me a favor, introduce yourself in terms of what's your name and what's the institution and where you work. Hopefully I would remember it. Inshallah. Okay? Yes. So first case. This is a 59-year-old female, history of cirrhosis, and when patients are is a candidate for a transplant, they do FDG PET in order to rule out any underlying malignancy, because malignancy will be an exclusion. They don't want to go through the expense of a transplant of an organ, and then it will turn out that the patient has some type of cancer. So it's not uncommon that we'll see these cases not because of any suspicion, but just as a pre-transplant evaluation. You will notice this is what's called lived images, and this is the rotating maximum intensity projection images. So it's always when you're reading PET scan, you look at it because it gives you a global idea about what's happening in the patient and if there's anything that's abnormal. You'll notice in this case that there is kind of mild diffuse uptake in soft tissue. And that's probably because of the underlying liver and potentially renal disease in this case. So I'm going to show you a transaxial cut, and then there will be the question, okay? So here's the transaxial cut. I'll give you 30 seconds to look at it, and then there will be a question about that particular transaxial cut. Try to get closer so I can see what you're looking at, and it may look different from where I am. Actually, this is small groups. I don't need to use the microphone. Okay. Okay. Done? Don't be stressed. It's fine. So here's a question. Here are the options. So statistically speaking, you have 15% to 20% chance to get the right answer anyway, so don't worry about it. So what would you do next? And by the way, I just took the recertification for the American Board of Nuclear Medicine, because every 10 years you have to take it. And they changed the format. It used to be, what's the diagnosis? And they no longer ask that. It's always what to do next. So they're expecting you to know what's the problem, but they're asking you management question. And this is actually even in the American Board of Radiology now. They no longer, or more commonly, they're asking you about management question than the diagnosis. So here are the options. What do you do next? Negative PET CT, proceed with the transplant. Technically suboptimal, repeat the PET CT. Mammogram for the right breast lesion. Mammogram for the left breast lesion. Right pleurocentesis. And I'll give you a second to look at it again. So what do? Do you go ahead with the transplant, repeat the study because it's suboptimal, or do a mammogram for the right breast lesion, mammogram for the left breast lesion, or right pleurocentesis because you have some pleural effusion here. Now what? Please, goodbye.
وانت قاعده مكانك معاك الميكروفون والجو.
حضرتك معلش اسمك؟ محمد سعد. ده الصعيد الحقيقي. Okay, so the rest of the team, do you agree, disagree? Someone disagree? Or do you agree? Okay, what is it? Why? معلش اسم حضرتك؟ دعاء بتقول to the right breast lesion.
Hi, I'm nuclear medicine resident, National Cancer Institute. The left breast lesion, I think it's not suspicious, and there is a pleural effusion. I think the pleural effusion needs much more investigation.
Okay, so you're selecting the right pleurocentesis. Okay, so دعاء قالت right mammogram وما يقول pleurocentesis.
إسرائيل خولي مدرس مساعد National Cancer Institute.
Okay, Mr. Raiki.
I think I need to see the map image again. I think there is some uptake at the right supraclavicular region. I need to see.
But actually, you're right, but this was not the pathology. So I want you to focus on this. Pathology, if any, is here.
I think to do left mammography.
Okay, why?
Because there is very small uptake, not very faint uptake at the left axillary lymph node. Yes, it needs further assessment or by MRI.
Okay, so there is a very subtle lesion in the left breast. So it's right. There is a very subtle lesion. In the FDG-ability of breast lesions, it's variable, and in some cases can be minimal uptake. So if you see the same degree of uptake in the axilla, you may brush it off and say this is normal physiologic uptake, but any mild uptake in the breast should be considered suspicious until proven otherwise. Particularly in this case, you don't want to have the patient being exposed to a transplant and then a few years later it turned out to be that the patient had a widespread disease from a misdiagnosed breast cancer. So it's one of those areas that we always take a second look if there is something in the breast, especially when it's asymmetric, focal, even if it's mild, we still call it an abnormal. Okay? So we're going to go from Isra and then Ukhtiana. So the PET CT was read as 5 millimeter FDG added left breast soft tissue. Now keep in mind, whenever we report the lesion, we always have to report the size of the lesion. And this is impressive in the time of flight technology that we're able to see a lesion that's 5 millimeter, because people used to say anything less than 7 or 8 millimeter PET is not good for it. But actually, I've seen cases where we see as small as 2 and 3 millimeter lesions. And probably Dr. Khalid has seen some cases as well. Okay, so PET was read as 5 millimeter FDG added left breast soft tissue density of unknown significance. Recommend further evaluation to rule out malignancy. Okay, that's verbatim what was in the PET report. So here's the continuation of that case. Mammogram was done 2 days later and it was negative. Now what? What to do? Here are the options. Is it false positive by PET CT since the mammogram is negative? Proceed with transplant. Do you do PET 3 to 6 months? Do you do breast biopsy? Do you do breast MR? Do you do mammogram in 6 months? Go first.
Rahab Abdul-Majid, I'm assistant lecturer of nuclear medicine in I think I'll do a breast MR.
You do breast MR. So breast MR has high sensitivity in detecting breast lesion, but the accuracy of it depends on the experience and expertise of the reader. So the fact that you may have it, it does not mean that this is the best way to go, because if you don't have someone who's an expert, we do have people reading breast MR, and they are kind of okay in the reads, but not really great experts in it. However, we have seen cases like that the mammographer, who's the radiologist and who also she does the breast biopsy, was burned before in the past, where, meaning she had cases that we said it's abnormal, they did the MRI was negative, and then it turned out to be positive later on. So here's what happened with this case. Ultrasound, so because of the PET was, the ultrasound did not provide an explanation for why we're seeing metabolic activity. If they say we see something and it is fibroadenoma, then at least you have an explanation. But if they say totally negative, then they fail to provide an explanation of why there's a metabolic activity and somewhat focal. So that's why she was kind of concerned. She called me and I said, I'm not comfortable brushing this off. I don't want someone to sit on it for 6 months and proceed with the transplant. So as a result of that, they went ahead and biopsied it, and it came back as infiltrating ductal carcinoma of the breast. So the take-home message is that you have to, what's called in the US, stick to your guns. Meaning when you feel that there's something abnormal, you have to follow it up. Don't just say, no, the mammogram is negative, I'm going to stop. Yes?
My question is, you have to use all your non-invasive techniques before you proceed to an invasive technique like biopsy.
Correct.
That's what I was thinking.
Correct, but it's just if they had done breast MR, it would have been fine and acceptable. But sometimes you have, if this patient is on a transplant list and there's some time crunch in getting an answer, whether should we proceed with the transplant or not, you may not have the luxury to wait for a month or two before you can make that decision. And the mammographer at that time called me and she said, do you think I should do a biopsy? And I said yes. So she went ahead and had the biopsy, and in retrospect, I'm glad that we went that way, because if the MRI was done and it was negative, then it will be 2 negative tests against 1, and they may have proceeded with a transplant. And these patients, once they have a transplant, then they are immune suppressed. And as a result of that, we had a study before that was presented at the European meeting that if someone had a transplant, then and they develop cancer, then it's more aggressive and typically we present with a significantly higher staging than the average because of the inherent immune suppression that they have because of the transplant.
So if you have MR, then you can use some time to send the patient to MR. So if you have MR machine.
Yeah, I mean, if you have yes and no, Dr. Mike. The MR would require special coil to image the breast. So the problem is when you do the PET MR, then you're going to do the kind of the run-of-the-mill standard whole body MR. It's not going to be maximized or optimized for a particular organ. So it's not going to be the best MR that you get when you have a dedicated breast MR.
But I think the technology, and approaching it to optimal, how to optimize the techniques for MR. And
but it's not there yet.
But in this case, if you have the ability to do PET MR for such kind of patient, you are going to do it, or just you will send it to PET CT?
Well, you mean from the beginning?
Yeah.
No, from the beginning, PET CT is the standard of care in these cases. Because, I mean, PET MR, we still don't know, and that's why I was talking to Naval yesterday. The problem is, in PET MR, you cannot do anything with the lungs. And the lungs, whether it's a site of primary or metastasis, if you go back to this presentation, the potentiality of things in the prostate, in the brain, and but the area of the lung, there's no arrow because they cannot. So if you ignore the lung in cancer searching study, it's a big limitation. So 2. 56-year-old male presenting with chest pain. Okay. Okay. So to give you a minute to look at this one. The problem with the symptom mammography in this case, number one, is at that time we did not have a SPECT CT. So if we see some uptake, it will be very challenging to know whether is this the same uptake that we see in the PET or a different area. Number two, this was kind of very close to the lesion detectability because this is a 5 millimeter lesion. So it would have been challenging to do symptom mammography under these circumstances. Right. Well, I have one nucleomedicine study saying there's something going on. If I have another nucleomedicine study, I didn't change the pretest probability. What we need is either something to say this is definitively negative or something that would say definitively positive. So if I had a symptom mammography and it's showing some metabolic activity, I did not change the algorithm that much. So, yeah, generally, yes, absolutely. Especially if you have SPECT CT. Although the issue of radiation to the breast, as you can imagine, is a sensitive subject. Dr. Reem, she's considering coming to St. Louis. Go ahead, further. So here's, you have some idea about what's going on in the patient now? Maybe? Yes? No? Okay. We'll go back to it. So here's the actual images. So this was the reprojection images, and now you have all the cuts, the standard cuts in nuclear medicine, looking at MPI, myocardial perfusion imaging. This was actually one of the questions in the American Board of Nuclear Medicine for me this year, October of last year. Is there anything that you look at right now that's saying, what is that? That looks different.
Right axis. Right axis.
So you mean can you be more specific in the total?
Dextrocardia.
Okay, so why are you making this comment?
Because I think the septal wall is on the opposite side.
Okay, so that's an excellent observation. So normally when you look here at this view, you see that the lateral wall should be longer than the septum. Here is the opposite. Okay, so here's the opposite. So you're looking at a mirror image of it. Now let's look at this again. Okay, so here are the options. Which of the following is the best choice? Situs solidus, situs inversus with dextrocardia. I'm not going to make it easy for you. Positive MPI, ischemia, and prior MI. Situs inversus with levocardia, dextrocardia. Perfect. 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 So it's dextrocardia of just the heart, but here's the heart. Okay, so it is kind of pointing in the opposite direction than the usual, and then here's the liver. So the liver is actually in the spleen is on the right side, and the liver is on the left side, and the heart is on the right side. So it's a dextrocardia. That's by definition from the heart, but it's situs inversus because of the rest of the organs. Situs inversus with levocardia will be rarer because it will be situs inversus in the organs, but the heart is still on the left side. And dextrocardia will be just the heart. So you're absolutely right. The cytosolitis is just to confuse you, but this means everything is in place. Okay. Case 3. الدكتور خالد ساعد شوية. قلت لك الصف الثاني ده نسيت. Okay, so 54-year-old male, history of hypertension, hyperlipidemia, end-stage renal disease, status post-renal transplant, presenting for preoperative clearance. So typically you do MPI for preoperative clearance, right? Just say yes. Say yes. Yes. Okay. So, so patient has multiple disease. So again, when you read the history, you have to just pick what are the key words here. Okay? So the key words: hypertension, hyperlipidemia. These are common reasons for people to have heart issues. End-stage renal disease, another reason. Post-renal transplant, patient had renal transplant, presenting for preoperative clearance. I think it is knee surgery or something. So whatever the surgery is not the question. Here is the rotating reprojection images. في شيء صعب. معلش أنا عارف اسم حضرتك في الانستيوشن. مفيش حد من أسيوط تبيك أب؟ مفيش حد من صعب مسح معلش آسف طب أنت قاعد هناك ليه؟ شفت بقى عشان رفعت إيدك؟ Okay, hold on, please. And here are the images, by the way. So basically, and I captured this in the grayscale just because it's easier to see the abnormality sometimes in the grayscale than the color scale. In this case, it is easier. Here are the options. Which of the following is the best choice? Coronary artery disease, liver disease, coronary artery disease, and liver disease, negative MTI.
I think the liver disease, I couldn't see the liver in the projection images.
Okay.
I didn't see any perfusion abnormality in this system. And I think.
Okay. So you're partially right, partially wrong. You're absolutely right in the observation. What he's talking about is that if you look at the rotating images here, this is the heart, and there is like a almost photopenic large area in the region where the liver lives. Typically, you have some uptake in the liver. If you don't see uptake, then that's indicative of significant liver disease. And in many cases, we diagnose liver disease by looking at that reprojection images. So the idea when you look at these images, you can detect abnormal system maybe uptake, whether it's a breast lesion. I showed you yesterday example of a large, huge hiatal hernia. You can have evidence of extravasation, but then this is kind of all above the diaphragm, but then also below the diaphragm, the liver. You can get somebody. In the previous one that Kim looked at, you saw that the liver was in the opposite side of the normal location, but in this case, there's a big hole where the liver is. So that's indicative of liver disease. But if you look closer at this one, you see that there is mild ischemia in the inferior wall. So that was actually the read, that there was coronary artery disease and liver disease. And here is the liver. It was a multicystic disease in the liver as well as in the kidneys. We're not really looking at abnormalities in the kidneys in the MPI, but we do look at the liver uptake, and actually we had a presentation at the ESNMS of kind of 12 different findings that you can find from looking at the projection images of the MPI. So that was the CT showed polycystic renal and hepatic disease, and it was read as mild ischemia in the basal inferior wall and increased uptake in the liver consistent with polycystic involvement. Not that it's diagnostic of that, but we saw that this was a liver disease, this was the outside CT, and when we called, we got a report that it was a polycystic disease, so we said it's consistent with Bob. Bad yet? Okay. 69-year-old male, history of diabetes, hypertension, chronic kidney disease, presented to the ER complaining of left chest pain and tenderness. Cardiac cath was negative for coronary disease on workup. He was found to have a large prostate and a PSA of 106. So basically, the patient went to the ER for multiple reasons. Incidentally, was diagnosed with having large prostate and a PSA of 106. FNA of the prostate was positive for adenocarcinoma. Okay? Bone scan. Okay, so you're saying we're not seeing the left kidney. Well, actually, I'm going to show you the questions. I'm going to show you the questions and then I'll go back to the bone scan. Okay, so here's the question. This patient has which of the following? Single bone metastasis, no definite evidence of metastasis, advanced prostate cancer, absent left kidney. These are the options. No kidney, single lesion, negative study, advanced prostate cancer. Okay, so he's talking about some abnormality here.
Yes.
Okay.
Ascites, I think, chest.
Okay. Maybe ascites. Okay. So you're saying no visualization of the kidney. She's correct. When you are suspecting non-visualization, you have to validate or confirm that in the posterior views because the kidney is closer to the posterior. So you have some mild uptake. Okay, what else? So what are the options? So the absent kidney is out.
I think advanced prostate cancer.
Okay.
No definite evidence. Red lesion, the equivocal.
Okay.
Maybe stress or traumatic, maybe due to ascites.
Okay. So, but
No
then why are you
evidence.
saying advanced prostate cancer?
No definite evidence or advanced, like in absent kidney with a single metastasis excluded.
Yeah, pick one.
No definite evidence.
No definite evidence. Actually, the answer is definitely advanced prostate cancer. and I'll tell you what, as much as we talk about the new technology and high-end spec CT and high resolution, something as simple as the bone scan that we're used to reading in a minute or two, single lesion, think of taking kidneys, and move on to the next case. But if you take your time, you'll see definite evidence of advanced prostate cancer in this case. Not in the form of bone metastasis, but you pointed to something which is ascites. But more convincingly, you see what's happening here in the right kidney? You have back pressure here. Okay? So there's something that is pressing the ureter. Okay? So that's a question mark. What would be pressing the ureter right there? And then, more importantly, more convincingly, if you continue into your imagination, you'll see that there is asymmetry in the size of the leg. The right leg is larger. So you start putting it together and you think maybe there's a lymphedema and there's a bunch of lymph nodes here that is blocking the ureter, causing that back pressure, as well as causing lymphedema in the right leg. Right? And that's how we read it. And yes, I'll show you the exact read. I read this one, and we all make mistakes. Okay, so it's one of those things, either I'm going to be dead wrong, or I'm going to be really very proud of that read. Okay? And of course I'm going to show you the one that I'm proud of the read. I'm not going to show you the dead wrong. So this was verbatim the read. Focal activity left 6 costocondral junction, giving the solitary nature. I'm showing you the verbatim so you get used to how you articulate things as well. Given the solitary nature of the lesion, it is believed to be more likely benign. Okay. If the patient has a PSA level that high, PET-CT scan is recommended for further evaluation. Why is that? When you have aggressive type of cancer, in fact, some of these cases may be aggressive with normal PSA level. FDG PET may be helpful under these circumstances. It's not something that you will start in imaging prostate cancer, but if you have high pretest probability of a metastatic disease and the bone scan is negative, then it's not wrong to proceed with having an FDG PET. Okay? Prominent activity in the right ureter and right pelvic cell system. This and the right lower extremity swelling with increased soft tissue activity can be due to mass effect from right iliac lymphadenopathy and lymphedema. Okay. Here's the FDG PET. See what's happening here? All of these are lymph nodes. Here is the transaxial cut. See the lymph nodes? They are bilateral para-aortic nodes, but certainly more on the right side, including going down to the right iliac, and that's why you're having the lymphedema in that side. What's interesting in this case is that the patient also had tons of bone lesions that were missed in the bone scan. So in some of these cases, but that's not the routine. But some cases I've seen where FDG PET will show lesions, skeletal lesions in prostate cancer that were missed in the bone scan, but that's not, normally it's the other way around. Okay, next. 56-year-old male, follicular lymphoma, initially diagnosed in 2009, and recurrence from the left inguinal node. Mediastinal biopsy was positive for lymphoma. Patient status post chemotherapy in October of 2010. So if you read a question and you have dates in the question, then that's relevant. Okay, so there's one baseline and one post-therapy. That's basically the question. And that's what I'm showing you here. So the one on the right is the baseline and, well, this one. And then this is a follow-up study. Now the abnormality is on this one, okay? And I'm going to ask you about it. Which you see here, the transaxial cuts, which is this area here. Skin contamination, lymphoma, melanoma, viral disease.
I want to compare between the baseline and follow-up.
Okay, so here it is. I don't expect you to know the answer for this particular one, but I want to hear your thinking about it. Let's go through this again. Here is how it would look like. So can you describe for me what you are seeing? What you're seeing? And these are the options. So could this be contamination? Could this be lymphoma? Could be melanoma? Could be viral disease? Pass? Pass? Pass يعني تعديها بحد تاني يعني؟ Okay, دكتورة بتقول melanoma. Agree, disagree, any other suggestions? I mean, I'm not saying right or wrong, but I just want to hear your thoughts.
I think to be a viral infection.
What would be? Why do you think viral?
Yes, it has a lymphoma. Maybe.
Perfect. That is actually the answer. So it turns out that these patients who are getting chemotherapy,
سبع أبليكات مدرس مساعد طب النوم مالطا.
It's a viral disease, and this was actually shingles. So when patients, cancer patients are receiving chemotherapy, they can have reactivation of the viral disease and shingles. And that's why preventatively and prophylactically, they preemptively give them treatment for that. This patient did not like that and stopped taking the medicine. And as a result of that, he developed shingles. And what I mean, I'm impressed that you were able to get the answers, but what I was trying to get you guys to do is to just think, can this be contamination? Not really. I mean, obviously contamination can look like anything, but there's a little bit of mild, very mild thickening. So there is something going on, not contamination. Contamination is not going to cause thickening, so that's out. And if you say it's melanoma, it's not going to be regional. It's typically focal, and the degree of uptake is higher. And lymphoma, typically will have some lymph node involvement, and it's not going to be that. So the key here is that it is a superficial, it's real skin issue, and it's kind of regional. So this was the patient hatching. Yeah, we're actually working on this descended as a case report because it was never published in the literature. Even though I was surprised to know that all oncologists, oh yeah, that's shingles. 69-year-old female presenting with history of breast cancer, status was mastectomy, prior bone scan was negative for metastasis. Okay, so bone scan negative for metastasis, patient had history of breast cancer. Here's the bone scan. I mean, I didn't tell you we're going that way. And then. So bone scan, take a look at it, anything abnormal, and then here the question will go back to the bone scan. Negative study, probable sinus disease, probable isolated metastasis, probable contamination. Here's the clinical data. Okay. Mina, Doctor. Yes?
I think this sinus uptake.
Okay, so sinus uptake. Sinus uptake. Agree? Agree. Okay, so it's a correct observation. There is definitely sinus, but this is a little bit more than the usual, right? I mean, normally you have a little bit of sinus, but this is more than the usual. Do you agree with that? Yes. But it can happen. It can happen. But I just showing you the added value of having the CT right there. So under normal circumstances, you'll go through a lot of explanation of the uncertainty that you can say it's sinus disease, but malignancy cannot be ruled out. This could be isolated metastasis, and you get to order an X-ray for that. But when you have a CT as part of the spec, then you don't need to have that because you're going to have the CT information, which is better than the X-ray, but then also you're going to have the diffusion, so you will see that the uptake perfectly fusing into the maxillary and the ethmoid sinus. So it's just an extreme case of sinusitis in this patient. By the way, if you see uptake, then if you see fluid like this density, then you will say it's a sinus disease. But if you see uptake in the FPG, then or the MDP in this case, then it's a sinusitis. So that's the difference between having a sinus disease versus having inflammation or infection. But I can see how impressive the degree of uptake in the transaxial component. Okay, next. 78-year-old male, history of prostate cancer, presenting with soft tissue density in the right lower pelvis, detected on contrast CT. This is my all-time favorite case. Yeah, I do. Yeah, I do. لا يعني الدور دي سهلة. دكتورة انتي معك ميكروفون. Go ahead. Okay, so we established this is history of prostate cancer. The contrast CT showed the soft tissue density in the right lower pelvis. Here's the arrow pointing to where the soft tissue density. Okay. Okay, so here's the CT read for that density. 1.7 centimeter soft tissue density in the right lower pelvis. Differential, again, this is verbatim from the CT report. Differential includes metastatic lesion, possibly from prostate cancer, right? The patient has prostate cancer, versus necrotic lymph node. I think the way the radiologist read it is confusing, because if it is a necrotic lymph node, then it would be metastasis from prostate cancer. So I don't know why or. I mean, it's the same thing, right? If it's a metastasis, then it is going to be a lymph node. And chances are, if the patient has history of prostate cancer, then what's common first is what you know. Okay, so here are the choices. Oh, actually, here's the problem. PET-CT was performed 3 days later. Okay, so we saw a lesion. We did not see the one that was, if you notice, was on the right. Okay, now on the PET, we show it on the left. So here's the CT of the contrast. CT showing it on the right. The CT from the PET-CT, which is done 3 days later, showing nothing on the right, and now it's on the left.
Something is moving.
Okay, so مش نفس العيان ازاي؟ دي اسمها الفقاقة المصرية. ضحكت عليك. روح السجن فيها. Okay, so okay, here are the options. What is the most likely diagnosis of the pelvic peritoneal soft tissue lesion? A metastatic lesion, a mouse, a polyp, biopsy to rule out malignancy. حد من السenior type who did that. That was actually a very interesting for us to learn about this.
mouse. أنا مش عارفة يعني إيه mouse.
mouse يعني فار. فار يعني.
maybe a mouse زي fibroid في أو fibroadenoma في البريست.
He's a male. Prostate cancer. She's not a fibroid. Should not be a fibroid. نفس الفكرة. Okay. Any other answers? Huh?
إنها bilateral دي ليها يعني.
Yeah, it's not bilateral. It's the actual thing that it moved.
البوليب should be البول بيتحرك يعني.
Moving with. Okay, so he's saying it could be with the bowel, but actually it's not attached to anything. Okay, so the gastric rule by itself is moving. This is actually something called peritoneal mouse. she was right for the wrong reason, but she's still right. So this is how we read it. Right perirectal soft tissue density present on CT is not seen in the current study. However, a similar soft tissue density is now seen on the left without increased FDG uptake, likely peritoneal mouse. So it turned out that there is peritoneal mouse is something that's an appendage from the colon, and it will over time detach itself and may have a rim of calcification around it. And if you do CT contrast, it may have peripheral enhancement. It will show up with no FDG avidity, and that's very important because on the CT, they would read it as a necrotic node. But for us, we would read it as a mouse based on lack of FDG avidity, but more importantly, based on the fact that it changed location. So you can image this patient 3 days later, and it may go back to the right side or even move up or down. The issue is that this peritoneal mouse, it does not have a blood supply, so it freely moves. It's not attached to anything. So that's why it moves, and that's why the term peritoneal mouse. And it is described in the CT literature but it was never described in the PET literature, and we just sent it as a case report, documenting it for the first time. So it was actually interesting. And it's one of those things that once you see it once and you understand, since then, which I've never seen it before, I've seen it 3 times since then. So I was just...
we shouldn't interpret every lymph node as peritoneal node.
No, you have to have the proof, meaning you have to have the proof. If it's a lymph node, then it should not move. Okay? So you have to have the evidence of it. I don't want people to overcall everything mouse. If it's not a common thing, but it's not unheard of, and if you look it up, Google it, you'll see that it is described in the CT literature, but not in the PET literature. But I'm just presenting for us to learn in reading PET that even we're still learning about things. So I didn't know about this one. We had to look it up and we had to learn about it. And we saw the uniqueness in the opportunity that it was never described before, so that's why I was in it as a case report. So, case 8. يعني الميكروفون في الميكروفون ضعف
لم يكن الصف الاولاني
Okay, 71-year-old male squamous cell carcinoma of the esophagus. I don't remember. Oh, okay, now I remember. So here is the rotating images. This is the actual big, huge, ugly esophageal FPGA esophageal lesion. This was a student doing a butcher job with the injection, so there's a lot of extravasation. But that's not the issue. The issue is here. The arrow is pointing at something. And here is another arrow that's pointing at something. Let's focus on this one because it's clearer than the other one. So it's kind of round, hypodense in the CT, not showing a lot of uptake on the PET. You agree? Okay. So now here are the options. What's the most likely diagnosis for this lytic appearing lesions? Non-FPGA lytic metastasis, degenerative changes, bone island, bone infarction.
Bone infarction.
Okay, you're right. Okay, that's good. But why?
Lytic lesions, I think it's FDG most of the lytic lesions.
Okay, absolutely right.
It's not the degenerative changes.
Why not?
Because it's not
joint.
in the joint, yes.
Excellent.
And it's not about bone and CT, it's hyperdense.
Excellent. Excellent. So this is, I'm just showing that the CT part of the PET CT can be helpful because if you look at the PET only, it would be difficult to characterize that. But this is a chronic infarction where you can start having fat changes within the infarction. So actually, if you put the region of interest, and you'll see that it's a negative value, indicative of a fat changes within an area that a clean trim, so that will be indicative of a chronic, long-standing infarction. Now it's fun. Because it's not. Because in this case, it's not perfectly in the joint, and if it is degenerative, then you'd expect some mild to moderate to intense uptake, some uptake in the FDG, because typically it would be showing some uptake if it is degenerative changes. This is kind of clean, round, and the convincingly hypodense by the Hounsfield units. It's not going to be hypodense. It will be hypodense, but not fat, not that negative. So it was read as such chronic infarct with fat replacement. Case number 9, 54-year-old male with non-small cell lung cancer. Something subtle, but here is the bone scan. this patient. Go ahead. Just take a look at it for now. And here the read now. So this was the read of the bone scan. Focal increase uptake in the left proximal fibula. Here's the lesion. Metastasis cannot be ruled out, given, again, this is a patient with non-small cell lung cancer. Recommend FDG PET-CT for further evaluation. You may have noticed also that there is some uptake in the chest wall here. So we recommended FDG PET-CT. And here's the FDG PET. Actually, I showed you the rotating images. This is the FDG PET-CT. And that's why you may even notice that there is a little bit of subtle uptake right there. This was a lung lesion. But that's not the question in this case. The question about the tibial uptake. And also the rib uptake that we saw on the right chest wall. So here is the transaxial. So this is static limb. And here the transaxial, and here is the left fibular abnormality. Okay, so here are the options. What's the most likely diagnosis of the left fibular sclerotic lesion? Mild FDG uptake, blastic metastasis, old trauma, bone island, bone infarction. Doctor?
I think it could be mild FDG after blastic metastasis.
Now, try not to use I think it could be. Okay, now let's say you can say I think it is, but just you have to have a little bit more likely this, less likely that. So more likely what?
It's better than CT. I think it's suspicious.
For metastasis, you mean? Okay. Just for the interest of time, because I have another really long case to show you. It would not be a blastic metastasis because the primary is lung cancer. And lung cancer typically will give you a lytic lesion. And the degree of uptake, if this is a blastic lesion, will be significantly higher than that. This is mild, right? So typically, you'll have higher uptake than that. It would not be an old trauma because the trauma that we have, you may have noticed in the static images that the right chest wall abnormality in the bone scan, we're not seeing this in the FDG PET, and that's the standard, that if you have fractures or a trauma, it may last for many years in the MDP scan and normalize within a couple of months in the FDG PET. So that's actually the fact that PET is negative in the right chest wall. That's indicative that this is not malignancy and this is a trauma related. But this area, the key thing is the CT characterization that there's some calcification in this area, right? So that's not a blastic metastasis because blastic metastasis would not cause calcification, it would cause blastic changes. It would not be an old trauma, we agreed on that. It would not be an old bone island because it doesn't look like a bone island and it's not a location that you will have bone island frequently. So the answer is actually bone infarction. So I'm showing you kind of two extreme examples of bone infarction. It may present with no FDG avidity at all, and it may present with mild FDG avidity. If it's early infarction, it will, relatively early, it will present with some uptake. If it's a long-standing chronic infarction, it will be cold. It would not show up with any metabolic activity. From the CT, you have a spectrum. It can have calcification in it, but it can have, over the years, fat deposits in it and tend to be hypodense with a fat density in that area. So just be aware that bone infarction is not uncommon. Now, 16-year-old male with lymphoma diagnosed from the left axilla. Here is the FDG PET scan. You can see multiple lesions in the axilla, and then there's some nodes in the abdomen. Here the transaxial cuts showing nodes in the pelvis. Here is the question. You see some uptake in the focal uptake in the left kidney. Okay. PET-CT was read as FDG avid left axillary node, retroperitoneal mesenteric node, suspicious for malignancy. Focal area of intense tracer activity in the upper pole of the left kidney may represent urine activity. You agree so far? Okay. Here is the bypass the ultrasound and the MRI. So here is the MRI for this patient. You can see that there is contrast enhancing lesion in that area. MRI, long report, but bottom line is they were not sure. They are saying this is consistent with a simple cyst, given the patient's history of non-Hodgkin's lymphoma, the possibility of renal involvement with lymphoma in this region must be considered. This is kind of a fancy way of saying, I don't know. Okay. And there's some nodal disease. Here's so they did an ultrasound. So here's the ultrasound. I don't read ultrasound, but here's the read. Again, long story short, possibility the area of enhancement along the posterior aspect of the cyst represents a tumor which abuts a Bosniak type 2 cyst should be considered. Bosniak classification is a way of grading the renal cysts from 1 to 4, and is in correlation with PET. Here's the second PET, showing if you remember, the left axilla lesion is less, the pelvic nodes are gone, so there's partial response to therapy, but we still have this focal uptake in the left kidney. Here's the read for the PET. Persistent focal abnormality in the left kidney upper pool may represent activity in a dilated calyx. However, correlation with ultrasound is recommended. So we went from the PET to the MRI to the ultrasound to another PET to the recommendation of ultrasound. So they ignored the ultrasound recommendation and went to the contrast CT. Now this is a pediatric case, by the way. So here is the contrast CT. CT showed still stable, low attenuation lesion in the left kidney, but still does not meet strict CT criteria for simple cyst. Again, correlation with PET scan is recommended. Sometimes when you have too many toys in the house, then
how can we assume a focal activity as a
well, because you can have focality in the uptake in the kidneys. You have normal physiologic uptake in the kidneys, and the patient has history of lymphoma with involvement in that area, as well as the axilla. So it's a question, it can go either way, meaning it can be urine and it can be a lesion. A dilated, yeah. It can be retained activity within that kidney for whatever reason. So you'll get the answer for this question. And that's why I'm showing you the case for a reason. So here's the follow-up PET. Now this area looks larger. Okay, so I'm sorry? We'll wait. So basically, it's getting larger. Okay, so that was my day of reading. So there's internal increase in metabolic activity of the left upper port renal lesion suspicious for persistent tumor. That was my colleague's read. And then, so this is where, fast forwarding to June 2nd, 2011. But the follow-up, this patient was scheduled for renal biopsy on July 22nd, okay, and had another PET scan the day before the renal biopsy. Now, renal biopsy in pediatrics is not a simple matter. It's an invasive issue. And keep in mind, everything else responded, right? There's no longer any activity in the lymph nodes or the axilla. So if it wasn't for that renal, you would say it's a complete response to therapy, case closed. But now what? So here is I know it's a very long introduction. Here are the questions. What to do? So you're reading this and there is this focality, everything else is negative. What to do? Do you do delayed images? Do you do ultrasound, MRI? Do you proceed with a biopsy? Or do you say, get a second opinion, I'm tired of this case?
I'm tired of this case.
Okay. Agreed. Yes? No? CT urography. Okay. Okay. So to do another test.
The patient is exposed to, the patient is exposed to many sets of radiation when he is 16 years old. So why don't you go with the biopsy from the after the second?
You certainly can, and you can definitively answer it by biopsy. But what we did is, I thought that this was an example that even in the U.S. you can have just a lot of back and forth in between the modalities, and each one is sending to the other. But I felt, okay, it's time to resolve this. And if we fail to resolve it, then the biopsy is tomorrow. So I'm not doing anything that is dangerous or harmful. So let's do delayed imaging. Here's the delayed images. So let me just remind you of how it looked like. So there was some activity on the, this is the left side and this is the right side. Is that correct? Yeah. Right side and left side. So the right side in the delay cleared. We didn't have activity in the ureter, and now we have little activity in the kidney itself. But the left side, which is problematic, still showing a focal. Okay? So, Cody, here are your choices. Okay. To biopsy, but she'll hand the microphone.
I think a doctor
Okay.
partial defect.
Partial defect? Yeah, she needs that.
ورايح الذهن خالص.
لا بيقولوا مش عايزين حاجة invasive بيقولوا partial defect.
دكتور مدحت partial defect عشان القطر بتاع حضرتك.
Okay, so here are the options. More delayed images, ultrasound, MRI, biopsy as planned, get a second opinion. I'm really tired of this case.
يعني حتى لو قلنا مثلا مور دي ايميجي مش
يا ريت
اوكي بس مش يعني لو اخذنا دي مش هيضرنا مش هيضر يعني ممكن لو انا مش هيضر بس ادينا الدايجنوزس ممكن نعمل بايبسي
Okay, so at the same time, with more delayed images, and it's not wrong, but I wanted to resolve it definitively. And since the delayed images did not answer, I have one of two options at this time: either to say I gave up, we're going to proceed with the biopsy, but I felt this is not pathology because it did not make sense. Patient is showing complete response everywhere else. There is something wrong with the story of patient having this lesion for a year, but then responding everywhere else and not progressing in that area. So to me, I felt this is normal physiologic activity. And by the way, a simple way is to get the SUV and see if it's kind of more of a urine level. If you're getting 20, 30 SUV, then you know this is urine activity. It's not going to be a lesion. But in this case, it was kind of the SUV was about 10, if I remember correctly. So it still can go either way. But what we did is we gave Lasix, and here it is. It's gone. لا ما حبيتش احط ليزكس عشان ما تبقاش باينه قوي يعني. I was delayed بس after giving Lasix and it cleared and we canceled the biopsy and the pediatric oncologist was very happy. All right. Thank you so much, and I'm going to run to the train.